Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. They will be useful to fourth year students for oral exams as well as for theory exams. And once in a while, you will see this group of people in your everyday practice. Today we are going to deal with one of the another important neurological topic, that is meningitis. So meaning is very simple: meninges and itis, involvement of arachnoid matter and pia matter. That's why it is also called leptomeningitis. We'll be dealing under this heading: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. So meningitis is involvement of meninges, that is layer which covers the brain and spinal cord. And we know very well there are two layers which are very close to the brain, that is pia matter and arachnoid matter. So involvement of these two matter we call leptomeningitis or we call meningitis. And when along with meninges, if there is an involvement of the brain surface, then it is called meningoencephalitis. Some of the common cause as far as meningitis is concerned is viral infection, which is enterovirus, and another common virus is herpes virus, that is virus 1 and 2. Among bacterial infection, Neisseria meningitidis and streptococcal pneumoniae. Among fungus, Cryptococcus and Coccido. And non-infectious group can be lupus, sarcoidosis, drugs, etc. Incidence of meningitis is 1.3 per 1 lakh population. Average age is around 41.9, but it is also very common in children. It is more common with immunocompromised host. There is an increased risk of unimmunized person against particular bacteria like streptococcal pneumoniae and H influenza. And particularly if the person has got some nasopharyngeal abnormality, they will be more prone to get meningitis. We'll be dealing in detail. This is just an introductory part. So meningitis is inflammation of brain and spinal cord meninges. Meaning, Greek word menin means membrane, itis means inflammation. So inflammation caused by infection like virus, bacteria, parasites, fungus, etc. We call that as infective meningitis or infectious meningitis. While among non-infectious agents, we'll be coming across like drugs, vasculitis like SLE, or maybe because of other conditions which we put them into non-infectious group. So there are some terms like meningitis, inflammation of meninges, encephalitis, infection of a brain parenchyma, and when both are involved together, that is inflammation of meninges plus brain, meningoencephalitis. And there is one condition, aseptic meningitis, which is inflammation of meninges with CSF. There is no presence of bacteria, or we call sterile CSF. This is labeled as aseptic meningitis. Meningitis is also labeled as cerebrospinal fever. Most common cause of meningitis is bacterial and viral. Meningitis caused by bacteria is very frequently life-threatening and can be treated with antibiotics. Viral is not commonly life-threatening But when bacteria invades the body, they can cause meningitis, they can end up into septicemia, and when meningitis with septicemia are together, the mortality rate is very high. And classical example is meningococcus. There are few terms which are very frequently being utilized. Depending upon the etiology, some terms are bacterial meningitis, viral meningitis, fungal meningitis, and among fungal, cryptococcus is one of the most common. Tubercular, or we call mycobacterial, parasites, rickettsia, and non-infectious group, that is drugs, etc. We also divide into acute and chronic. The most common cause of acute is bacterial and viral. Among chronic, fungal infection is common. Mycobacterium tubercle can be chronic. Even parasitic infection, rickettsial infection, invariably they are chronic. There is another word which is being utilized is patchy or lepto. In lepto, pia and arachnoideae both are involved. Community acquired is by common organisms like streptococcal pneumoniae or Neisseria meningitidis. While nosocomial, or we use the word iatrogenic, these are usually E. coli, Klebsiella, Pseudomonas, those group of organisms. And opportunistic is usually in a person with HIV, or we call AIDS, or person with an immunocompromised person. Person who is on a steroid, person who is on anti-cancer drugs, person who has got bone marrow failure, or person who has got a pancytopenia. Those group of people will be more prone to get opportunistic infections. And in opportunistic, fungal infection will be more common. Say like in COVID-19 also, fungal infections are quite common. Other odd infections which are not routinely seen in a human being. And we have already mentioned aseptic will be because of meningitis without presence of bacterial, which cannot be detected in CSF. That's why it is also called aseptic or non-bacterial. So common terms: acute, chronic, community acquired, nosocomial, opportunistic, aseptic. These are the common terms. And you can see here, by and large, the 67% is nearly meningococcal, 12% is pneumococcal, 10% is other bacterial, viral is only 5%, and in 6% the etiology is not known. So the commonest cause of meningitis bacterial, another is aseptic meningitis, viral, chronic, and non-infectious. When you say non-infectious, it is one of the condition we put them, that is aseptic meningitis, and viral and chronic are usually non-bacterial infection. Acute pyogenic is usually we call bacterial meningitis. Aseptic meningitis, very frequently it is a viral meningitis, and chronic is very frequently tuberculosis or fungal, that is cryptococcus or coccidomycosis or spirochete infections. So those are the most common cause of those, and aseptic can be non-bacterial, which can be viral, fungal, or maybe non-infectious group. You can divide into acute, subacute, and chronic. Acute is usually one very rapidly developing, which is within 1 to 24 hours. If it is between 1 to 7 days, it is called subacute, and when it is longer than 7 days, it is usually put into a group called chronic. Among etiology, bacterial infection comes topmost on the list. Second common is viral. In India, Mycobacterium tubercle is also one of the common, and among fungal, Cryptococcus. Among protozoa or parasites, one of the most common is P. falciparum. Again, that is quite common in India. Among protozoal infection, and fowleri and toxoplasmosis. Rickettsial infection is not so common in India but can be there. Among non-infectious group, drugs, or maybe because of physical injury, or maybe paraneoplastic, or even vasculitis in case of an SLE. This could be some of the other causes. So, aseptic meningitis is non-bacterial. So, we divide into two big groups, viral and bacterial. Among bacterial, pneumococcal meningitis, Neisseria meningitidis, and Haemophilus bacteria, H influenza bacteria. So, pneumococcal, streptococcal pneumonia will account for almost 38 to 50%. Neisseria meningitis will be accounting for 14 to 25%, and H influenza is 4%. While Staphylococcus aureus will be accounting for 5 to 15%. And tuberculosis is still common in India, and that is Mycobacterium tubercle. So among bacterial, H influenza, Meningococcus, Pneumococcus, Streptococcus, these are common, and Mycobacterium tubercle. Among viral, influenza, Encephalitis, West Nile, then Japanese encephalitis, etc. Those are quite common. So among viral meningitis, mumps, chickenpox can be there as a common cause in children, and maybe mosquito borne, particularly some cases can be there, and the commonest organism is enterovirus. Another common is poliovirus, which can be type 1, type 2 or type 3, and another Coxsackie virus type A and type B. You can also have HIV involved meningitis, measles, variola, rubella, rhinovirus, and varicella zoster virus can involve meninges. So among viral, enterovirus, that is Coxsackie virus, HIV, then mumps, cytomegalo, Epstein-Barr, varicella zoster, measles, rubella, influenza, etc. are some of the common viral infection which you can come across. So all those viral infection we already mentioned. Among non-infectious group, malignancy, sarcoidosis, vasculitis, dural vein sinus thrombosis, migraine, drugs like cotrimazole, IV globulins, non-steroidal anti-inflammatory drug can produce non-infectious group. And they can be a combination of aseptic meningitis with encephalitis syndrome, can be together. So meningoencephalitis is more common with herpes simplex, rabies. There are a lot of different types of arthropod-borne viruses like St. Louis, Eastern equine, Western equine, West Nile, etc. And they are very common in USA. Aseptic meningitis can be non-infectious group, or good number of time bacteria that do not grow on a standard media can be diagnosed as aseptic meningitis. If person is already treated with antibiotics and lumbar puncture is done, after that you may not be able to detect the bacteria in CSF, then also it is labeled as aseptic meningitis. Virus, fungus and parasite will be usually, because in those groups bacteria cannot be grown, so virus, fungus and parasite will fall into an aseptic meningitis. So the most common cause of aseptic meningitis is usually vasculitis, para-infectious syndrome, particularly acute demyelinating encephalomyelitis, and toxins and drugs. This comes very frequently in case of aseptic meningitis, which are put into non-infectious causes. So aseptic meningitis is bacteria cannot be isolated from CSF. Very commonly viral, partially treated bacterial meningitis, tubercular meningitis, fungal meningitis, malignancy like lymphomas, sarcoidosis, collagen disorders, etc. There will be other groups also, enterovirus, HSV virus will be responsible for aseptic meningitis. You can have infections like fungal, that is Cryptococcus, coccido, parasites, toxoplasmosis, and you can have sometimes odd infection like Borrelia, Mycobacterium tubercle, Trypanosoma pallidum, Mycoplasma, Rickettsia, Chlamydia. These are rare but can be there, and they will not be grown on a routine culture. So they will be put into a group, aseptic meningitis. We have to investigate properly if a person is diagnosed as aseptic meningitis. Among drug, non-steroidal anti-inflammatory drugs, sulfur trimexazole, pyridium. Among malignancy, lymphoma and leukemia. And among autoimmune, vasculitis in case of SLE, sarcoidosis, and even Behçet syndrome. So this could be big group which can be leading to aseptic meningitis. Fungal meningitis, particularly Cryptococcus, very common, and coccidomycosis. They are more common in the person with immunocompromised host or person who are on treatment for AIDS or person on treatment of cancer or person who is on a large dose of steroids, etc. or person who is on immunosuppression drugs. Tubercular meningitis is very common in India, but the percentage is now less, and you can develop these different groups of infections because of poor hygiene and polluted water also. Opportunistic infection is very common in person with HIV and immunocompromised host, where you will have odd infections like Aspergillus, Candida, mucormycosis, and odd protozoal infection like Toxoplasma, etc. So in immunocompromised host, you can have a hospital-borne infection like Klebsiella, E. coli, Pseudomonas, Staph aureus, those groups of organisms which are not routinely seen in normal person. And you can have a severe gram-negative infections. Also odd infections like Listeria also, which are more common in immunocompromised host and elderly persons also. Odd organisms, we already mentioned in fungal, Cryptococcus, coccido, then mucormycosis, aspergillosis, candida, histoplasmosis, etc. Among parasites, toxoplasma, hydatid, or we call tinea echinococcus, entamoeba histolytica, P. falciparum, cysticercosis, etc. And among rickettsial, Rocky Mountain spotted fever, all these are quite common. Some of the infection can lead to chronic meningitis like Cryptococcus, coccido, which are fungal infection, Mycobacterium tubercle, another bacterial infection common in India, and some of the bacterial infection, particularly Brucella, Nocardia, Borrelia, etc. can end up with chronic. And among non-infectious groups, sarcoidosis, paraneoplastic or secondary metastasis like lymphomas, leukemias, etc. Wegener granulomatosis can end up with chronic. So do keep this thing in mind. Recurrent meningitis is also labeled as Molleret's meningitis, which is most common with HSV2 virus, and very commonly it is because of cryptogenic infections, and it may respond to antiviral drug, that is acyclovir. So it is more common with such type of infections, and also it will be in an immunocompromised host. Risk factors more common in children's. H influenza is more common. Meningococcal infection is very common in children's. In elderly, pneumococcal is more common as compared to Listeria groups. Particularly fractures, skull fractures, that is cribriform plates, basal fracture skull, they are more prone to get infections. Head injuries, neurosurgery, etc. are also more prone to. Chronic alcoholic, person with malignancy, person who are on steroids, diabetic person, HIV person or AIDS, and person who are on immunosuppression drugs are also more prone to develop bacterial meningitis. Asplenia, hypersplenism, pancytopenia, person who are on drugs or on immunosuppressions, immunocompromised host, diabetes, person who are having already tuberculosis, neutropenic person, person who are on radiotherapy, anti-cancer drugs, person with bone marrow failure, leukemia, person who has already got very common in children, particularly measles and herpes simplex virus, also they are more prone to get meningitis. Among pathophysiology, we know that the brain is protected by three layers, that is pia, arachnoid and dura mater, which tries to protect the meninges, will protect the brain from getting infections, and skull bone itself will also prevent the entry of organism, direct entry of organism inside into the skull cavity, as well as blood-brain barrier system will also protect the entry of organism into CSF. So brain is protected by skull, meninges and blood-brain barrier system. So if by any mechanism, either by a direct entry or by blood-borne or by continuity, if once the bacteria enters into the skull cavity, they will multiply, they will liberate the toxins which will produce general symptoms and signs and local inflammation because of release of inflammatory mediators like interleukins, TNF alpha, etc. And that will also stimulate the irritation and inflammation of meninges, which will give rise to meningeal signs in the form of a neck rigidity, KERNIG sign and BRUDGKINKI sign. Inflammation of choroid plexus will give rise to increased CSF production. Increased production will lead to increased CSF accumulation, raised intracranial pressure, and later on it can end up with even herniation. We'll be going through different parts now. Hematogenous spread is the most common means of entry. So the microorganisms which are present already in the body, which are present in GI tract, lungs, say person might have a chronic focus, which is already considered as a primary focus like sinuses, dental infections, skin infections, lung infections, urinary tract infections, bone, etc. And the commonest organism in all those are different at different places. Say in a skin, it will be Staphylococcus or Streptococcus. In the nasal cavity, it will be Streptococcal pneumoniae. In GI tract, E. coli, urinary tract, E. coli. So whenever the immunity decreases and person becomes immunocompromised, this organism can easily enter into the bloodstream and can give rise to hematogenous spread. Direct entry of organism will introduce the organism which are there in a atmosphere due to head injury, open fracture skull or basal fracture skull, congenital malformations like spina bifida or meningomyelocele, or while doing some procedures like ventriculography, pneumoventriculography, or burr hole with biopsy, lumbar puncture, cisternal puncture, fontanelle punctures. Those are all called iatrogenic, where organism can be introduced from outside. and it can be nosocomial infections, and this will be Klebsiella, Pseudomonas, E. coli, and maybe a virulent organisms. Local extension from nearby area like otitis media, which will be most frequently staphylococcal infection, sinusitis, chronic sinusitis, dental abscess, particularly in a upper jaw, and all those will be most common will be staphylococci, Staph aureus, that will be most common. So otitis media, sinusitis, dental abscess, this particular can have a local extension into the cranial cavity. And already we have mentioned that any immunocompromised host who is on anti-cancer drugs, immunosuppression drugs, steroids, large dose of steroids, etc., as well as person who are diabetic, HIV person who is on a or already has developed AIDS, this will be immunocompromised people. Bacteria once gains an entry into the CSF, and if our immunity is very low, bacteria will be entering from primary focus by blood-brain, we call hematogenous spread. And the commonest organism we already mentioned, streptococci, staphylococci, and E. coli, if it is from GI tract or urinary tract infection, etc. In the oral cavity, you can have a candidiasis also, which can enter. Once the bacteria can enter either by the direct route or by a bloodborne or by means of a continuity. Fungal infection will be very common in an immunocompromised host or by continuity from oral cavity or from nasal cavity into a skull, or very rarely by direct entry in a open fracture skull. Viral will be more common with bloodborne or by continuity. Tuberculosis will be bloodborne from lungs, from lymph nodes, or from abdominal tuberculosis. And parasites will be very common by bloodborne spread. We'll be mentioning mainly regarding bacterial infection. Some of the things we are mentioning in general, but bacterial infection will be hematogenous spread from dental abscess, mastoiditis, sinusitis, otitis media, osteomyelitis, infective endocarditis, pyoderma, septic arthritis, penetrating cranial injuries, spine surgery, brain surgery, VP shunts, VA shunt, lumbar puncture, cisternal puncture, or fontanelle puncture, etc. All this can introduce infection from outside. This particular, all this, VP shunt, VA shunt, lumbar puncture, spine surgery, brain surgery, penetrating injury will introduce organism from outside. And this will be iatrogenic. This last four group will be iatrogenic. While this will be the primary focus, and with low immunity or immunocompromise will easily enter into hematogenous and can spread to the brain. Lung abscess, bronchiectasis, empyema, pyelonephritis will be usually Staphylococcus. In case of pyelonephritis, E. coli will be most common. Skull fracture, extradural abscess, subdural empyema, spinal epidural abscess, patchy meningitis, all this will be again infection which can easily spread and give rise to meningitis and even encephalitis. Organism which directly enters into the CSF from the skull cavity will be usually virulent organisms, maybe a multi-organisms, mixed organisms, rare organisms, and sometimes it can be associated with fungal also. So in direct entry, usually they are virulent organisms or mixed groups, including even fungal. Commonest cause of direct entry will be fractured skull, penetrating injury, lumbar puncture, spinal anesthesia, VA shunt, VP shunt, burr hole, ventriculography, intracranial pressure monitoring, etc. You will have a direct entry into the skull cavity. Sometime post-surgical, post-procedures, particularly nosocomial infections will be very, very common. In case of spina bifida and meningomyelocele also, you can have an entry of organisms into the CSF. Continuity wise, from sinuses, from dental abscess, from ear, in sinuses, maxillary sinus will direct gain and entry into the middle cranial fossa. Frontal sinusitis and ethmoidal sinusitis will gain an entry into the anterior cranial fossa. Dental abscess, particularly maxillary dentation, that will gain an entry directly into middle cranial fossa. Chronic otitis media mainly into the middle cranial fossa and posterior cranial fossa. Panophthalmitis into middle cranial fossa, and any injury over the face and nasal cavity will involve the cavernous sinus and will gain an entry into the middle cranial fossa. This will be some of the common means that is spread from the nearby structure, that is continuity. So once there is an involvement of meninges, you get an irritation of meninges and you get a reflex spasm of the muscle, giving rise to meningeal signs in the form of the neck rigidity, KERNIG signs and BRUDGKINKI sign. Because of liberation of the toxins and inflammatory mediators, person will have symptoms like fever, headache, body ache, etc. Among immune response, person can get an immune response. There will be inflammation and swelling and edema, and this will give rise to altered level of consciousness. Inflammation of brain will give rise to seizures, and because of excess of CSF collections, person will also have headache. So raised intracranial pressure will produce severe headache, vomiting and papilledema, and that is because of raised intracranial pressure, person can also develop Cushing Triad, where person will have a wide pulse pressure, elevation of systolic blood pressure, bradycardia and bradypnea. This will be classical Cushing triads because of a raised intracranial pressure. And because of now raised intracranial pressure, you can have a third cranial nerve, sixth cranial nerve, most common, third and sixth will be most common being involved. So you can have a pressure palsy on third and sixth cranial nerve, more common. Fourth cranial nerve is not commonly being involved, and seventh cranial nerve is also not commonly being involved, but maybe occasionally. But olfactory can be involved because of increased pressure in the anterior cranial fossa, and optic nerve may be involved because of inflammation around the optic nerve in case of meningitis. You can have bacterial meningitis converted into an abscess, and when it when it ends up with fibrosis, fibrosis is more common with tubercular meningitis rather than bacterial meningitis. So if the fibrosis results, the CSF drainage is affected and it can end up with hydrocephalus. In case of a virulent organisms, you can end up with septicemia, particularly meningococcal, then it is called meningococcemia, and it leads into a condition we call Waterhouse-Friderichsen syndrome, where you can have an extensive subcutaneous hemorrhages and also acute adrenal crisis. Because of raised intracranial pressure, herniation, and you can have herniation of cerebellum with medulla, we call tonsillar herniation, which can be lethal and person can have even mortality in the form of a death. Pathophysiology wise, once the microorganism gains an entry, they multiply, and Lysis of the organism will be by bactericidal antibiotics. Release of bacterial cell wall components, that is endotoxins, etc., will give rise to inflammatory cytokine release. And because of this inflammatory cytokine release, there will be alteration in the blood-brain barrier, permeability will increase, which will result into vasogenic edema. Permeability of the blood vessels will increase, leak of plasma, that is protein, into CSF. And because of increased plasma leak, it will give rise to exudate formation, and that will obstruct the outflow. And because of obstruction of the outflow, person will have increased intracranial pressure, and you can develop obstructive or communicating hydrocephalus. Either obstructive or communicating hydrocephalus can end up. Because of increased permeability due to alteration in the blood-brain barrier system, leukocytes also migrates into CSF. They will liberate toxic metabolites, and because of liberation of toxic metabolites, you will have a cytotoxic edema. Person can develop even damage to brain in the form of strokes, seizures. Because of cerebral ischemia and decreased blood flow also, you will have chance of development of stroke and seizures. And cytotoxic edema, vasogenic edema, and because of obstruction to the outflow, you will have a raised intracranial pressure, and because of raised intracranial pressure, person can develop Cushing Triads, herniation, and person can also have an altered level of consciousness. And when the raised intracranial pressure is tremendously high, tonsillar herniation and mortality. Because of adherence of leukocytes to the cerebral capillary endothelial cells, again they will liberate out toxic metabolites and gives rise to further alteration in cerebral blood flow, that is decreased blood flow or increased blood flow, will also result into cytotoxic edema. Production of different toxic metabolites and reactive materials, nitrogen species, etc., cell injury and death can occur, and that will also increase the chance of raised intracranial pressure. So all these things will be producing different symptoms and signs in case of meningitis. So from nasopharyngeal, or we call continuity, local invasion, bacteremia, meningeal invasion, it will enter into the subarachnoid space. Then they will release the bacterial components, that is, will give rise to attraction of macrophages, neutrophils, etc. They'll release cytokines, and because of release of cytokines, subarachnoid space inflammation, increased CSF formation, hydrocephalus, interstitial edema, raised intracranial pressure, as well as release of different mediators, microvascular, cerebral, microvascular, endothelium will be affected, blood-brain barrier system permeability is increased, vasogenic edema, and because of inflammation, cytotoxic edema. All those will give rise to raised intracranial pressure, and finally that will disturb the function of brain, and also there will be local damage also. So bacterial lysis can give rise to release of mediators and can finally end up with cytogenic or vasogenic edema, and there is a release of interleukins, TNF alpha, etc. We call cytokines release and inflammation. So inflammation can produce neurogenic damage and can also give rise to thrombosis, which will produce vasogenic edema and can give rise to different symptoms and signs. This is little bit can also produce SIDH also. So you can have a lot of different things which is happening in case of a meningitis. At your leisure time you can go through. From primary focus, you can end up with bacteremia, meninges, brain parenchyma can be involved. You can have a rich focus which will rupture into subarachnoid space, will results into vasculitis, adhesions, and encephalitis. Encephalitis will produce cerebral edema and results into raised intracranial pressure. Vasculitis can produce stroke and can involve basal ganglia, etc. Adhesions will produce hydrocephalus or can produce cranial nerve palsy particularly. This will be more common with tuberculosis. As far as clinical features is concerned, general symptoms and signs because of bacterial infections, release of endotoxins and exotoxins. You will have a high grade fever, body ache, loss of appetite, headache, leg cramps, etc. Secondary to elevation of raised intracranial pressure, vomiting, we call projectile vomiting, severe headache, and blurred vision because of papilledema. Because of meningeal irritations, neck rigidity, KERNIG sign, BRUDGKINKI sign. And in a children, we might see even opisthotonus. Because of irritations and inflammation of cerebral cortex, convulsions, altered level of consciousness right from drowsy, stupor, and coma. And raised intracranial pressure will produce compressive palsy in third cranial nerve and sixth cranial nerve, which will be very common. Particularly in case of a bacterial meningitis and in case of tubercular meningitis, olfactory and optic nerve can be also involved. Because of involvement of the blood vessels, you can have strokes, which can produce neurological symptoms and signs. So symptom signs will depend upon the bacterial infection or not, bacterial, viral, tubercular, etc. Will also depends in an acute variety, it can be fulminant. In a chronic variety, it will be a gradual development of symptoms and signs, as well as it will depend upon how severe the damage is. As far as acute is concerned, most common organism is streptococcal pneumonia and Neisseria meningitidis. Among subacute variety, H. influenza is quite common. And depending upon the severity of infection, person will have symptoms and signs. The most common acute infection is by viral, which is less severe, which usually resolves without specific treatment within weeks or two. And usually it comes into a group we call as aseptic meningitis, and commonest organism is enterovirus. While among bacterial infection, usually it is severe. It ends up very frequently with a brain damage and neurological symptoms and signs with raised intracranial pressure, etc. So bacterial meningitis is more dangerous than viral meningitis. So we should pick up those cases and make early diagnosis. In acute meningitis, particularly viral meningitis and bacterial meningitis, flu-like symptoms will be more common with viral. But person with bacterial meningitis will have a high-grade fever, severe headache, and altered level of consciousness will be very early. In viral, rash will be more common. As far as chronic meningitis is concerned, it is a gradual onset or insidious onset. Person will have a headache for weeks, low-grade fever, usually along with chills and sweating. Person will have a little amount of weight loss also, quite common in chronic meningitis. Among bacterial meningitis, in an early stage, you will start getting inflammation of meninges giving rise to KERNIG, BRUDGKINKI sign and stiff neck. Focal neurological symptoms and signs, altered mental status, and particularly in case of Meningococcemia, you can have a rash, but rash are more common with viral infections rather than bacterial meningitis. So you can have a prodromal period where person will have a fever with general symptoms and signs like body ache, headache, loss of appetite, little nausea, vomiting, little rash, etc., which comes in a prodromal period. And there are two other periods which are being divided because of septicemia, that is release of toxins, and because of involvement of meninges. Because of release of toxins, fever with chills, headache, you might develop petechia or purpura, and you might have splenomegaly. Because of meningitis, headache, vomiting, stiff neck, KERNIG sign, BRUDGKINKI sign. That is most common. And once there is an increased production of CSF, person will have a raised intracranial pressure, and person will start producing projectile vomiting, unbearable headache, and papilledema will give rise to blurred vision. And depending upon early diagnosis, early treatment, person will go into convalescent phase, where symptom signs will gradually disappear and person may recover completely. If not diagnosed early, not treated properly, or not diagnosed early, and if treatment is not complete, or if there is a very virulent organism and if a person is an immunocompromised host, person will develop chronic or acute complications. Commonest symptoms and signs we have already mentioned: fever with chills, vomiting, confusion, irritability, drowsy, severe muscle ache, skin rash, particularly in case of a meningococcemia, severe headache, neck rigidity. Then person can have photophobia, phonophobia, convulsions, seizures, etc. There are a lot of pictures which we have got. So fever, nausea, vomiting, then cry, typical cry, irritable, neck rigidity, then altered level of consciousness, lethargic, etc. In adult, stiff neck, headache, fever, vomiting, then convulsions, body ache, drowsy, altered level of consciousness, photosensitivity or photophobia, phonophobia will be quite common. Here you can see that person will have good number of symptoms: knuckle rigidity, lethargy, apnea, apathy, jaundice, pallor, shock, hypoglycemia, convulsions, anorexia, coma, fever, tachycardia, diaphoresis, seizures, weakness, photophobia, phonophobia, headache, aching muscles, lot of symptoms and signs. There are big groups of symptoms and signs. In children, these are very common: fever, nausea, vomiting, refusing food, irritable, skin rash, cry, stiff neck, altered level of consciousness, altered behavior. You can see big list. Almost we have repeated many of those symptoms: headache, altered mental status, photophobia, phonophobia, stiff neck, high grade fever, rash, etc. So hyperpyrexia, photophobia, painful eye, fatigue, myalgia, vomiting, diarrhea, abdominal pain, rash, petechia, purpura may be seen, and they are more common with viral and meningococcemia. Again, same big list, and person can even develop decerebrate posture, cerebral hernia. In children, you can have separation of sutures, bulging fontanelles. You can have Cushing Triad in the form of bradycardia, wide pulse pressure, etc. may be quite common. So do look for all those signs. So bulging fontanelles, papilledema, bradycardia, hypertension, irregular respiration, bradypnea, papilledema will be very, very common, and even person can have third cranial nerve palsy also. Here you can see that person has got neck rigidity, opisthotonus may be seen. That is more common in children rather than adult. So neck rigidity, BRUDGKINKI sign, KERNIG sign, vomiting, photophobia, rash, meningeal irritation is the most common signs. So stiff neck or painful neck, that is neck rigidity, BRUDGKINKI and KERNIG sign. Fever, altered mental status, quite common. Severe headache, photophobia, phonophobia, very, very common. Malaise, fatigue, nausea, vomiting, again, very common. Anorexia, skin rash. Skin rash is maculopapular rash. Right from that, you can have even bleeding and even petechia, or you can have even ecchymosis, very common in meningococcemia or meningococcal septicemia. It is very, very common. And you can have a vesicular lesion and in herpes simplex. You can have cold extremities, particularly in a septicemic shock, which is very common with gram-negative septicemia. Myalgia, arthralgia may be also one of the common symptoms and signs. Papilledema will be very common in raised intracranial pressure. Seizures will be very common once the person starts getting encephalitis. Cranial nerve palsy, among cranial nerve palsy, third and sixth cranial nerve palsy is very common. And you can also have involvement of olfactory, facial, and occasionally vestibulocochlear nerve can be affected. Third cranial nerve is the most common cranial nerve which is being involved, and second another common nerve is sixth cranial nerve. Skin rash will be very common in septicemia, will be also very common with gram-negative organisms in case of viral, and particularly don't forget meningococcal septicemia, and that may be leading to even acute adrenal hemorrhage leading to Waterhouse-Friderichsen syndrome, acute adrenal insufficiency. You can see here lot of rashes. Here you can see petechial to even a big ecchymosis. There are rash. This will be seen in viral as well as bacterial also. You can get conjunctival hemorrhage right from here. You can see a bad even vasculitis producing gangrene. You can see subcutaneous bleeding, big petechial hemorrhage. This is called Purpura Fulminants, quite common in meningococcemia, meningococcal infection. Purpura Fulminants. You can see an extensive bleeding. This is very, very common, Waterhouse-Friderichsen syndrome, and that is meningococcal septicemia. Mortality rate is very, very high, and you can detect that very easily. You can separate from other by doing a glass test. Try to differentiate that. So while doing a glass test, if there is a rash, press the side of a clean glass or a tumbler against it. If through the glass the rash does not change the color, contact the doctor. If the rash does fade away and loses the color under the pressure, it is unlikely to be meningitis. This helps you to detect subcutaneous bleeding, or we call petechia, apart from rash. You should be able to differentiate encephalopathy from encephalitis. So in encephalopathy, fever is more common, headache is more common, but mental status will change much more common with encephalopathy, and there will be usually steady deterioration, while in case of encephalitis it will fluctuate. Focal neurological signs will be more common with encephalitis rather than encephalopathy. In encephalopathy, it will be usually generalized symptoms and signs. Seizures will be also in the form of generalized, while in case of encephalitis, it may be focal or it may be generalized. Leukocytosis will be more common in case of encephalitis, which will be less common in case of encephalopathy, because encephalopathy can be because of multiple other like metabolic disorder also. CSF pleocytosis is more common with encephalitis rather than encephalopathy. EEG will show you focal abnormality, more common in case of encephalitis rather than encephalopathy. In encephalopathy, it will be generalized diffuse slowing of the electrical potentials. MRI will be very frequently may be normal, but in case of encephalitis, MRI will detect focal abnormality or focal lesions will be detected in case of encephalitis. This helps you, very, very important, because encephalopathy will be very common in a metabolic group of disorder also from encephalitis. Clinically, they may look similar, but you should be able to differentiate between encephalopathy from encephalitis. We have already mentioned that any person who comes to you with a suspected meningitis, when you do a lumbar puncture, if lumbar puncture shows you almost absence of WBC, you think of other groups like encephalopathy or maybe drug induced, etc. Those groups. While if you detect WBC in CSF and now you put it for a culture, if there is a no bacterial growth, we'll put them into aseptic meningitis, and if there is a bacterial growth, it will be bacterial meningitis. So this will help you to differentiate bacterial meningitis from aseptic meningitis from encephalopathy, or we call non-infective groups, which will be very frequently missed and misdiagnosed as bacterial meningitis. So that should be investigated properly. So among investigation, one of the most important investigations, one which gives you some idea regarding CBC, leukocytosis will be more in favor of bacterial meningitis, leukopenia will be more in favor of viral, lymphocytosis will be in favor of viral, bacterial or fungal infection, while neutrophilia will be more in favor of bacterial. CT brain will be partly helpful, and it will be helpful to differentiate between encephalopathy and encephalitis. CT, MRI will be helpful in that group. Lumbar puncture will be the most important thing, which will be helping you by detecting bacteria by Gram stain or by ZN stain, also by presence of WBC and differential count. Lymphocyte count will be elevated in case of a viral, bacterial and fungal. Viral, tuberculosis and fungal, while neutrophil will be very high in case of bacterial. Glucose concentration will be markedly reduced in case of bacterial, but may be close to normal in case of viral. And PCR will be very helpful to detect some of the viral organisms and also in some of the bacterial infection. And culture will be helpful, more common in case of a bacterial, and may be also helpful in case of a viral infection also. But lumbar puncture and CSF examination should be done before starting antibiotics, because after putting them on an antibiotic, if lumbar puncture is done, invariably you might have bacterial culture negative, and that will be misdiagnosed as aseptic meningitis. This should be kept in mind. Blood culture may be of help to detect bacterial infections, viral infections may be detected, which may be responsible for meningitis. And X-ray chest, renal function, liver function, ABG, etc. to find out the effect of meningitis, or maybe the primary defect in case of lung, kidney, liver, etc. may be a primary site for leading to meningitis. So blood culture, nasopharyngeal culture, lumbar puncture, going for PCR, maybe from blood or from CSF. Then you can have scraping done from bleb or skin, etc. to find out the organisms. So CSF examination, PCR, viral culture, rapid diagnostic test by doing serological or other laboratory study will be very, very helpful. CSF differentiation between bacterial, viral and fungal. We have already uploaded the CSF differential diagnosis and CSF analysis. You can go through. I'm putting these slides which will help you to give you an idea regarding bacterial, viral and tubercular. This is also slide showing you bacterial, viral, fungal and tuberculosis differentiation by WBC, protein, glucose, gram stain, pressure studies, etc. What we call as, when you do a lumbar puncture, we call a pressure which is while doing a lumbar puncture, and when you try to collect a CSF, we call opening pressure, and that can help you good number of time. So these are all opening pressure, color, cell, differential diagnosis, differential count, then plasma glucose ratio, protein, etc. will help you. So cell count, polymorph lymphocytes, glucose, plasma to glucose ratio, protein culture, gram stain, etc. will help you to differentiate bacterial, viral from tubercular. But before starting antibiotics, you must be able to differentiate between tubercular meningitis, viral meningitis and bacterial from other groups, that is aseptic meningitis, non-infectious group, etc. You should be able to differentiate. And also, good number of time person may be there with neck rigidity, which can be there in tetanus, ankylosing spondylitis, pontine hemorrhage, etc. And person might have fever with convulsions, maybe there may be good number of other conditions which should not be misdiagnosed as meningitis. As far as the treatment part is concerned, control of bacterial infections, simultaneously treatment for primary focus, treatment of precipitating factors like immunocompromised host, treatment of complication if there is any complication secondary due to pyogenic meningitis or tubercular meningitis, viral encephalitis, etc. You should have a good follow-up for ruling out complications. For pyogenic meningitis, antibiotics is very important. Antipyretics, IV fluids, steroid is given good number of time to prevent hydrocephalus. If there is a septic shock, DIC, seizures, raised intracranial pressure should be treated. And prophylactically, vaccine can be given to a children who are highly prone to develop bacterial infections and may be prone to get even pyogenic meningitis. You can give prophylactically vaccines during epidemics. Anticonvulsants, treatment of raised intracranial pressure, IV fluids, respiratory supports may be required in supportive treatments. So, metabolic imbalance treatment, correcting hypoglycemia, correcting metabolic acidosis, fluid balance, electrolyte balance, etc. should be corrected. Decreasing inflammatory reaction, toxic symptoms, cerebral edema, treatment for all those things. Then treatment of hyperpyrexia, seizures, treatment of raised intracranial pressure, treatment of septic shock and DIC should be done if those are the complications associated. Then you might require surgical intervention if the person has developed subdural effusion, ependymitis, you might require a drainage. In case of hydrocephalus, you might require a surgical intervention. And if a person has developed SIDH, you might require to restrict the fluid, diuretics, and sometimes even sodium replacement. Prevention can be done in a person who are highly prone to, particularly you can use pneumococcal vaccine, meningococcal vaccine and H influenza vaccine. Will be very helpful to prevent the infection in a high risk groups. Complications, some of the complications are very common, particularly in a pyogenic meningitis like brain abscess, cranial palsy, irreversible damage to the brain as well as cranial nerves, secondary seizures. In case of meningococcemia, Waterhouse Friderichsen syndrome and high mortality. Person can develop septicemic shock, DIC, SIDH, raised intracranial pressure. Person can also develop herniation and coning, hydrocephalus. All these can be complications. So complication can be coma, respiratory involvement, seizures, cerebral edema, vasomotor collapse, DIC, respiratory arrest, dehydration, pericardial effusion, and person can die. These are immediate complications, or we call acute complications. And among chronic complications, seizures, focal damage, subdural effusion, hydrocephalus, intellectual deficits, you can develop ataxia, blindness, adrenal hemorrhage, and even death. This is sensory neurological deficits. Hydrocephalus, subdural effusion, empyema, stroke, abscess, dural sinus thrombosis can be also some of the acute complications. Among chronic complications, cerebral edema, subdural empyema, effusion, abscess, seizures, shock, sepsis, deafness, cognitive impairment, chronic seizures, hydrocephalus, all that can be chronic sequelae, and this can be among acute complications. So sometime you can come across with SIDH, seizures, cortical vein thrombosis, subdural effusion, empyema, infarctions, cranial nerve palsy, septic shock. Those can be as an outcome. So I end my lecture here. I hope this will be helpful to you. Very frequently asked as a full question in your theory. Once in a while you will come across in your everyday practice, more common in children rather than adult. If you feel this lecture, if you like this lecture, don't forget to press button like, subscribe, you can share with your friends. At the end, you can give your comments so that I can improve. Thank you very much for taking out time. I know that your time is valuable and I appreciate that you have spent some of the time with me. See you in next lecture.